Hello, everyone. Hola, bonjour, guten Tag. I welcome you with great pleasure to session 2 of Nursing on the Front Lines of the Climate Crisis Education for Action. Today's focus is on vector-borne disease. I'm Dr. Michelle DePhillips. I'm an assistant professor at the University of Delaware School of Nursing and a nurse fellow at the Global Consortium on Climate and Health Education. Before we begin, a few housekeeping reminders. I encourage you to refer to our website listed in the chat. Here you'll find the course objectives, course schedule, and very detailed information, including session resources. Continuing education for United States-based participants is provided for this course. In order to receive credit, participants must attend the live session or view the recording and pass the post-evaluation session with an 80%. Following the webinar, attendees will be directed to Annie's Learning platform to access the webinar recording and post-session evaluation. Participants who attend live will be provided with a password to provide a bypass to the viewing requirement. Today's session will be 60 minutes long and will end with a question and answer section. As a reminder, please enter your questions for presenters in the Q&A function on Zoom, not the chat. Session video recordings, slide decks, and resources will be made available on the course website. This is linked in the chat. It is now my great pleasure to introduce Dr. Tracy Kelly. Dr. Tracy Kelly is Program Director of the Pediatric Acute Care NP program at the University of Virginia. Dr. Kelly brings more than 20 years of experience as an acute care pediatric nurse practitioner and more than a decade of experience in the classroom, having taught nursing students at Duke, Yale, and Seton Hall Graduate School of Nursing. Dr. Kelly's global work is both expansive and impressive. Most recently, she was the lead pediatric educator for the only tertiary children's hospital in Sierra Leone. With Partners in Health, she cared for Ebola patients in West Africa in 2014 and 2015, and worked for 2 years as a clinical mentor for the pediatric clinicians and nursing students with the Rwandan Ministry of Health. Dr. Kelly earned her BSN from Georgetown, MSN from UVA, and DNP from Yale, and has been active in her community as a volunteer with Eyes, Ears, Nose, Paws Canine Medical Training Program and as North Carolina Medical Advisory Disaster Preparedness Team member. Welcome, Dr. Tracy Kelly.
Thank you very much for the introduction, and welcome to all from around the globe. My name is Tracy Kelly, and I am a professor at nursing at the University of Virginia. I am also a board member of the Virginia Clinicians for Climate Action, which is a group of concerned clinicians and healthcare students who aim to increase content on planetary health into curriculum of nursing, medicine, and other allied providers. VCCA, as it's known, also has an advocacy mission to inform legislators to enact health policies consistent with environmental health. I'm a pediatric nurse practitioner, and I have the honor of working globally in Rwanda, Sierra Leone, Mauritania, the Caribbean, Cambodia, Indonesia, the United States, and other countries. So I welcome all nurses who are present on this call. Thank you for attending this important talk. The slides, please. So here are our objectives for this session. Thank you. Here are objectives for this section. Vector-borne diseases are a global public health concern, and as nurses, we have a duty to provide education on prevention, means to reduce transmission, and provide evidence-based care for patients infected with vector-borne diseases. So we'll look at the relationship between vector-borne diseases and climate change, identify our roles as nurses, discuss possessionality and intersectionality and how they shape discourse to exposed populations, identify the intersection and multisectionary measures at various levels to mitigate the risk, and define the epidemiology as they relate to climate change. Slides, please. Thank you. Last week, Dr. Parter showed this famous slide. I'm going to concentrate my talk on the changes in vector ecology on the right side in the sort of light brown yellow where you see that. But none of these impacts are in isolation. So while I may be discussing vector-borne diseases, it impacts environmental degradation and malnutrition too. These impacts are multi-layered. The talk is about the relationship between climate change and vector-borne diseases and the interplay of climate variables, human behaviors, vector adaptability, and how these factors drive pathologic transmission to humans. Slide, please. So you probably all have seen this Venn diagram, and we're going to go back to it several different times during this talk. This is a diagram of the 3 participants in infectious disease causation. The agent is the microbe or the pathogen. The host includes both the primary vector and the secondary human host, and the environment that allows the agent and host to meet, resulting in disease. So when you have them all meeting together, we see disease. We know that infectious diseases occur through various means. They include direct human-to-human transmission, such as in tuberculosis and measles, vector transmission, such as in malaria and dengue, vector transmitted zoonotics, such as Lyme disease and Zika, and then direct animal to rabies, as in animal to humans, as in rabies. The environment is complex. It's an external factor that allows the disease to spread. It's always changing, and it can extend and include physical, social, behavioral, cultural, political, and economic factors. What's interesting about all of these things in this Venn diagram is they all strive to survive and reproduce. Humans want to reproduce, vectors do too, and so do diseases, and so do microorganisms. Slide, please. So let's start with the definition of vectors, which very basically means a vehicle, generally some sort of living organism, that moves a pathogen from one place to the other. And it does this basically in 2 ways. One is mechanical, and this simply is a mechanical carriage. For example, an insect may be soiling its feet on feces, or a flying insect, and sometimes also the passage of the microorganism through the vector's gastrointestinal tract. But mechanical does not require replication of the pathogen by the vector. Cholera is an example of a mechanical transmission through the fecal-oral route of infected water or food, often by flies. Shigella by flies is another example. Biological transfer is the spread of a disease where a living organism takes in a pathogen and allows the pathogen to multiply within its body. And once the vector is infected with a pathogen, it then transmits it to a new host through biting or other contact. In biological transmission, there is an incubation period before the vector becomes infected. This is called the extrinsic incubation period. And I'll go through that a couple of times because that's a really important variable, and how temperature and other factors can change this extrinsic incubation period. An example of biological is dengue fever or chikungunya. So 2 different ways of transmission through vectors. One where the vector simply carries the pathogen from one place to another, and one where the vector itself is involved in pathogen replication and becomes infected with the microbe before it infects the human host. After I wrote this, I started thinking about one other means of vector transmission that I think is coming up more common, and I wanted to address it. The Lone Star tick, which is found largely in the eastern part of the United States, can bite a human, introducing a sugar molecule, galactose alpha-1 galactose, which is not a sugar that humans are comfortable with or have it in their body naturally. And if the tick introduces this sugar to the human host, it triggers an immune sensitization to red meat and dairy products. by the mammal who it was taken from. And these mammals can be cows, pigs, goats, lambs. This disease is named alpha-gal, and it's increasing across the globe. And ticks, besides the Lone Star, are infecting humans. So I think of this as sort of a new kind of vector-borne diseases that's sort of different than the others that we've discussed. Slide, please. Okay, so what are these vectors? For our discussion today, we'll narrow the vectors to arthropods, which are cold-blooded. This is important as we discuss later because arthropods cannot regulate their own temperature and are dependent on ambient temperature for survival. Arthropods include mosquitoes, fleas, flies, lice. Two predominant mosquito species that are responsible for most vector-borne diseases are the Aedes species, which are responsible for spreading things like dengue, Zika, chikungunya, Rift Valley, and has two different species, the Aedes aegypti and Aedes albopictus. They're day biters. That becomes important too. They bite during the day. And Aedes aegypti especially likes hot weather. And we'll talk about temperature in just a minute. The other species is the Anopheles species, which is responsible for Plasmodium malaria transmission. There are other vector-borne diseases that are not arthropods. So there are rodents that can transmit tularemia, and bats that transmit rabies, snails transmit schistosomiasis. But for this particular lecture, we'll focus on the arthropods. I want you to just take a quick look at them right now because there's two things I see right away. One is they're pretty small, and the second is they're pretty light. Looks like things can move them pretty quickly. Next slide, please. So vector-borne diseases include all pathogens that spread to humans by the bite of an arthropod. Most of those pathogens are viral, and so we use the term arboviruses, as in arthropod-borne viruses. But there are also some non-viral arthropod diseases that can cause human disease, such as parasites and bacterial diseases. And I've listed them, a few of them in this slide. Next slide, please. So regardless of whether the pathogen is viral, bacterial, or parasitic, changes in the environment can aggravate disease spread. So if we remember going back to the Venn diagram again, now I'm adding back in the environment. We all understand this idea of climate oscillation, which is a recurring expected pattern of precipitation, temperature, and wind change. And the best example of that is El Nino. So we expect these kinds of changes, but we also have unexpected changes in the environment, and we also have humans who change the environment too. They crowd cities, they build dams, they alter land use, and throw plastic waste in landfills. All of those become very important in changing both the pathogen and the vector. Next slide, please. So let's move on to discussing the diseases a little bit. Here is a list of vectors on the left side and pathogens that vectors carry just to the right of that, and then the diseases that transmit to the humans. You can see that the vectors, for the most part, the ones that I've brought up here are ticks, mosquitoes, fleas, and bugs. So I just wanted to go through some of these diseases. There's lots of them, there's many of them, but let's walk through a few of them. We can start with yellow fever, which is found in tropical areas of Africa and South America. The good thing about yellow fever is there is now a vaccine against yellow fever. And so if you're going to any of those areas, it's very wise for you to receive the yellow fever vaccine. Chikungunya is found worldwide, mainly in Africa, Asia, and India. It has some distinct symptoms, including fever and joint pain. And that joint pain can last a really long time on some people who contract chikungunya. So that can be a very debilitating disease for some people. Lyme disease is transmitted by the bite of a tick, the deer tick. And it's a bacterial infection rather than a viral infection. And it's noted for its bullseye rash. It's not always the case. Not everybody gets a rash, but those that do are diagnostic for Lyme disease. It's most common in the northeast part of the United States, southern Canada, and now in Europe. Rocky Mountain spotted fever is also transmitted by the bite of a tick, and it's also a bacteria infection. It can be very, very serious and in some cases even fatal if not treated early and aggressively. Rift Valley fever is found predominantly in sub-Saharan Africa, especially during heavy rainy seasons or years that have heavy rain. The concern about Rift Valley, among other things, is it can spread to livestock. So some of the animals can have premature deliveries of their animals. That can really significantly impact financial burdens on the country where they lose many of the animals from Rift Valley. And then I wanted to talk about West Nile virus, which happens to be the leading cause of mosquito-borne diseases in the United States. You can sort of tell from its name that it wasn't first discovered in the United States. It was discovered in Uganda. But it's now the leading cause of mosquito-borne diseases in the United States. And like other diseases, in some circumstances, particularly in the elderly over 60 years of age, it can be very, very serious, especially developing CNS system complications such as encephalitis or meningitis. So those are just an example of some of the illnesses that we see. Next slide, please. In the United States, the most common vector is the tick, but throughout the world, mosquitoes are the most common and the deadliest vector. Vector-borne diseases account for more than 17% of all infectious diseases, causing more than 700,000 deaths annually. Malaria, which I mentioned earlier, is transmitted by the Anopheles mosquito, causes an estimated 250 million cases globally, and it results in more than 600,000 deaths every year. Most of the deaths occur in children under the age of 5 years of age. Dengue is the most prevalent viral infection. It's transmitted by the Aedes mosquito. I mentioned this is a day biter. More than 3.9 billion people in over 132 countries are at risk for contracting dengue, with an estimated 96 million symptomatic cases and an estimated 40,000 deaths every year. For example, in 2017, 80,000 people contracted dengue in Sri Lanka. There have been other outbreaks in Vietnam, Burkina Faso, Cote d'Ivoire, and other countries recently. The burden of these diseases is highest in tropical and subtropical areas, and they disproportionately affect the poorest populations and children under 5 years of age. Zika was initially limited to countries in Africa and Asia, and rapidly spread across the Pacific into South and Central America, with devastating consequences to the fetus of women infected early in their first trimester. Next slide, please. Okay, so let's look more carefully at a specific pathogen, the vector life, and the human disease. This is a picture on the left side of the mosquito tick or the mosquito life cycle and the route it takes once it bites its human host. Let's assume this is the Plasmodium microbe, which requires a biological transmission. I mentioned biological earlier. And in this case, as I said, the pathogen multiplies in the vector. In this case, the Anopheles mosquito. Initially, a female mosquito, remember that the female is the only one that bites. In fact, male mosquitoes don't even have the mouth to be able to bite into a human. I want to mention that because the reason that the female bites is because they need the protein from the blood to reproduce, to lay eggs. So the male has no reason to bite humans or to extract any blood. So the female mosquito takes a blood meal from an infected human, and then the micro, it takes about 1 week to infect the mosquito. Then the infected mosquito transmits the pathogen to another human through a bite. And I include this slide because I want to emphasize again what's called the incubation period, or the extrinsic incubation period needed for the mosquito to become infected before it can transmit to the host. So the Plasmodium goes into the mosquito and it replicates there, but the extrinsic incubation period is about 1 week long. We'll talk about that in a minute, about whether or not that time can change and how relevant it is. The pathogen can also last through each of the stages on the left side, each of the stages of the mosquito life cycle, from the egg through the larva to the adult. But it's got to last all the way through that to be able to become infected. On the right side, the Plasmodium pathogen enters the human through the mosquito bite, then travels to colonize the liver, and then moves into the red cells or the erythrocytes. Next slide, please. Okay, so we've had all this information. Let's look at how significant climate change can impact vector-borne diseases. I sort of mentioned earlier when we looked at the arthropods that they're pretty small and they don't seem to weigh a lot. I also mentioned something earlier that's very important, and that is that they're cold-blooded, okay? We can also remember the other participants in the infection disease transmission, and that is human host and the pathogen and the environment. A change in one can significantly impact the others. The EIP strongly depends on temperature. Consequently, temperature has a direct impact on the transmission of vector-borne diseases. For each vector and pathogen, there is an ideal temperature at which the extrinsic incubation period is minimal. A shorter incubation period is actually advantageous for disease transmission, since vectors can then be infectious sooner. So if you can shorten that EIP, you can actually have an increase in the number of anticipated vector-borne infections. It also, a temperature can affect the biting behavior, the reproduction, and survival of the vectors. Humans have many conditions for survival. One of the most important is temperature. If it's too cold in the winter, we find a shelter with heat, with a heat source. If it's too hot in the summer, we go inside into the air conditioning. I call this a Goldilocks phenomenon. Humans move to conditions that are just right. Interestingly, vectors have their own Goldilocks condition. The most important is also temperature. In order to live, mosquitoes require temperatures somewhat above 15 degrees centigrade, but no hotter than 33 degrees centigrade. For people comfortable with Fahrenheit, that's somewhere between 60 and 90 degrees. If the ambient temperature falls outside of those ranges, the mosquito generally dies. There are two other important conditions to the mosquito, and that is humidity and precipitation. Because mosquitoes breed just above water lines in small areas of standing water, such as containers, gutters, discarded tires, and any area where a small amount of water are left standing for more than 3 or 4 days. So if we think of our own behaviors, how many times might we take maybe even feeding birds and have a container filled with water, standing water, for more than 3 or 4 days? That's a perfect breeding for a mosquito. Elevation is actually important as well. At lower elevations, mosquitoes can breed all year long, whereas at higher elevations, they can breed less so all year long and have certain periods where they breed. All of this is referred to as the climate envelope for a species. And humans, as I said, have a climate envelope too. So you can see how a combined effort of temperature and humidity affect the behavior, survival, and reproduction of many vector species. We go back to the Venn diagram in our minds. The ability of each participant to adapt is going to forecast outcomes in vector-borne diseases. Slide, please. So, how adaptable are mosquitoes and other arthropods? Can they expand their climate envelope? Some vectors have a very narrow range envelope, which means that they don't adapt well, and others have a wide envelope. Range shift is the adaptability of an arthropod to adjust to higher or lower temperatures, to survive in changing elevations, and to reproduce in drier and wetter conditions, essentially developing some sort of protective environment, same as what humans do, right? We build these houses, which are air conditioned and heated, and we're able to survive in the tropics as well as in the poles. As vectors develop more resistance to changing climate conditions, their range shift will expand. I give one example of not an arthropod, but for example, a small rodent who we know can start to build deeper and deeper burrows to survive cold but shorter winters, expanding their capacity to breed and survive. Because usually they would die in very cold, very long winters. Now that our winters are shorter, they find a way to survive. Some climate changes, such as warm temperatures or increased humidity, can actually favor vector survivals. And thus, we can expect to increase our vector-borne diseases. Rainfalls, increased humidity, extreme flooding, these are usually associated with increased risks of contracting vector-borne diseases. It also impacts other vector behaviors, as I mentioned, like biting rate of egg laying, the EIP timing, and the time to move from the egg stage to the adult survival stage. Next slide, please. Okay, so we've talked about the disease, we've talked about the vector. Let's talk about human factors that drive increase in vector-borne diseases. Behaviors such as how we use our land, how we store water and irrigation, deforestation, which is bringing more water into our urban areas, agricultural habits, movement of populations from rural settings to urban settings, trade and travel. We know that many vectors can travel, as I mentioned, into small rubber tires or rubber tires where there's a little bit, even an inch of water can breed a perfect mosquito or be a perfect site for mosquitoes. I'd like to also mention our health expenditures and access to primary health care. What's important in our primary healthcare setting, and how can we reduce vector-borne diseases? The economics of each country and political views. All of these external factors can impact the spread of disease. Next slide, please. Okay. So there are 4 basic principles that I've sort of talked about that will influence a pathogen transmission. We know if climate change is to affect the frequency of vector-borne diseases through acting on non-human host, vectors and pathogens, it's likely to act by one or a combination of 4 basic primary mechanisms. The first I mentioned a little bit ago, and that is range shifts in vector distribution that brings the vector into contact with new human populations. So what that means is that if you are in an environment that is outside the reach of most mosquitoes, but that environment changes and becomes warmer, then we're going to see more vectors in that area, and they will be in contact with humans. The second is changes in the population density of the vector that would result in increase or decrease frequency of contact with humans. So how many mosquitoes are bred, whether or not they can bred and survive, is going to increase that possibility. The third is changes in the prevalence of infection by the pathogen in the vector population that would also increase or decrease the frequency of human contact. So now we're talking about the pathogen. How easy is it for that pathogen to get into the vector? I talked about the EIP again. If the pathogen can replicate in the vector more rapidly, then we're going to have more spread of diseases. And finally, the change in the pathogen load brought about by the changes in rate of pathogen reproduction, replication, or development that would affect the likelihood of a human contact. We can influence these characteristics, but temperature, precipitation, and human behavior are all going to impact this. Next slide, please. So this figure depicts all of what we've discussed so far: the intersectionality of climate change, human behavior, the pathogen and vector, and conditions that bring them together. Examples on the left side of some of the factors that are affected by climate change: heating, drought, storms, wind, fire, all of the things that we sort of mentioned, and then the conditions of both the pathogen as well as the susceptibility and the transmission. Next slide, please. This article was written earlier this year, I think in April of this year, by Zane, and it reviews the climate change and its impact on infectious diseases in Asia. I want to mention this slide because its conclusion is really important. It goes through many of the vector-borne diseases that are seen in Asia. But one of the things it says at the very end of the article is that it highlights the imperative need for strategic intersectional collaboration at the national and at the global level, and for the health sector to implement adaptation and mitigating measures, including responsibilities for its own greenhouse gases. So the idea that we are each country is responsible for their own greenhouse gas emission and how they can implement adaptive and mitigating strategies to reduce that, I think, is an important message to all countries, especially those countries that are most responsible for changes in climate. Next slide, please. This particular diagram comes from the same article that I just mentioned. And if you can notice, we've got the Venn diagram that we've been discussing. You can see it right in the center of this picture, and it has the pathogen, the host, and the environment. If you focus on the left, the far left side, we're looking at greenhouse gas-driven climate change. And on the far right, the social behaviors that drive vector-borne diseases. We are going to make that center disease larger and larger as we change pathogen and vector-borne diseases and the host. Next slide, please. I think it's of some comfort to know that government agencies worldwide are considering the implications of climate change on vector-borne diseases. I found this picture. It comes from a workshop about 8 years ago by the National Academy of Science, Engineering, and Medicine. And they are discussing all the same things that we've been discussing today. So everybody is aware. It's important that we keep on discussing it and that each country identifies its own responsibility. Next slide, please. So let's look at how vector-borne diseases might impact a small country in Central Africa. We'll look at a scenario and let's pick out a country right in the center, what I call the belly of Africa. Next slide, please. So over the course of the last year, community health workers in a small Central African country are identifying more and more children under 10 years of age with fever, myalgia, and a petechial rash. Not surprising, standard treatment for children with these illnesses, certainly the fever, is treatment for malaria with a 3-day course of ACT. Many of the children progress and are transferred to the district hospital for care. District hospital provides oral rehydration solution, but unfortunately, several children die of shock. Hematologic studies don't confirm malaria. Cultures are also negative for bacterial infections, but some children are able to have serum serologies drawn and identify positive IgM for dengue fever. Next slide, please. So Rwanda is a country in Central Africa. This picture here is a representation of the healthcare system in Rwanda. As I said, I had the pleasure of working there for many years, and it provides outstanding primary healthcare. It's a landlocked country, and its structure of healthcare starts at the very bottom, at the village level, with community health workers, and moves upwards to the health post. You can see in this diagram that the largest percent of health delivery is through the primary healthcare network at the villages and the health posts and the health centers. So things like primary healthcare, vaccinations, maternal care is all given through a primary level, and it is the largest level of healthcare. District hospitals refer complex patients to the teaching hospitals at the very top of this pyramid. You can see it's the smallest percent of healthcare delivery because there are not that many teaching hospitals, about 5 in Rwanda. I want to also discuss healthcare expenditures per capita. In Rwanda, as an example, the healthcare expenditures per capita is $60. So for every person living in Rwanda, $60 goes to healthcare. By comparison, the United States healthcare expenditure is $12,555. In Germany, it's $8,000. In Japan, it's $5,250. In South Africa, just under $500. And in Kenya, a country that borders Rwanda, it's $83 per person. Next slide, please. Other things about the population of Rwanda. It has a population of 13.5 million. It has the second most dense population in all of Africa, with 578 people per square kilometer. Again, using the United States by comparison, they have a population density of 38 square kilometer. India has a population density of 488 per square kilometer. Rwanda's population is young, with a median age of 19 and many children under 5 years of age. And most people live in the rural setting, with only about 18% of the population living in urban settings. But that number is growing quite a bit. Next slide, please. So let's look at dengue fever. This is a list of some of the symptoms of dengue fever, which can range. I mean, some people have dengue fever completely asymptomatic. Other people may have a mild fever and nausea and vomiting and not have aggressive symptoms. But there are occasions, often seen in infants, where there's a plasma leakage and a potentially fatal dengue hemorrhagic shock. And so these are all of the symptoms that you may find in dengue fever. On the next slide, we'll see that there can be phases of dengue fever, beginning with the febrile stage, which lasts about 7 days. And they have the general symptoms that I just mentioned, as well as arthralgia and myalgia, and either a petechial rash or mucosal bleeding. Most people survive that period and go on to have well recovery. But there are a small number of people, again, as I mentioned, often young children and infants, that move into this critical phase that can last 3 or 4 days. And it's after they defervesce and they begin to develop this systemic vascular leak syndrome. You look at blood studies, they have low white cell count, low platelet counts, and low proteins. This period can progress without interventions to shock. After that period of time, if the patient is well cared for, they can recover, their well-being improves, their appetite returns, and their hemodynamic status stabilizes. Next slide, please. One of the interesting things about dengue fever is with the onset of the illness, as I mentioned in that first stage, the dengue virus can be detected in serum, in plasma, in circulating blood cells, and other tissues, but that only lasts for about 4 or 5 days, and then the virus disappears. Often without recognizing the illness early, detection will be uncertain. But you can detect the virus through antibody serologies in the later days after the first week. But antibody serologies can be a really costly method for many low-income countries, especially if it's in large volumes. Yet, as I mentioned, an early diagnosis of dengue infection is pretty important for fast recognition of the very severe symptoms of dengue. The cases that go into that critical phase require hospitalization for intravenous hydration and potentially blood transfusions. In addition, meticulous care of fluid balance, electrolyte monitoring, organ system is needed by all members of the healthcare team. Next slide, please. Dengue fever is the fastest spreading mosquito-borne viral disease worldwide. It affects over 100 million people annually. Over the last 50 years, the world has seen a 30-fold increase in the incidence of dengue fever in countries with little experience identifying the virus. So dengue was originally quite prevalent in Asia, but if you look at this map here, you can see how it's moving to countries all across the world. That's particularly problematic for countries that have epidemic or endemic malaria, where fevers often are treated with anti-malaria medications. Next slide. Predictive models anticipate the spread of vector-borne diseases such as dengue, as well as Zika and chikungunya worldwide. Low-income countries such as Rwanda may not have the financial support or strain on the health system to accommodate these new diseases. Next slide. So, public health has a huge role to play in recognizing, reducing, and communicating about vector-borne diseases through partnerships with government and global leaders, as I discussed in the one article, as well as ongoing research on the impact of climate change. From a very basic intervention of turning over standing water, counseling people to wear long sleeve shirts and pants treated with permethrin, sleeping under insecticide-treated nettings, spraying indoor areas, use of topical repellents. All of these may be used to repel mosquitoes, fleas, and ticks. Studies show that DEET-containing repellents are the most effective and longest protective, but it really depends on the percentage of DEET in some of the products. If you have less DEET in the product, it will not last as long, maybe 2 hours. If you have, say, for example, 25% DEET, it will last for 5 or 6 hours. Picardia is also another repellent that many people find a little bit more appealing. It doesn't have as much a smell. And people are also using eucalyptus and lemon oil that people feel repel the mosquitoes, although there's not as much research on that. Speaking of research, I read a recent study where CRISPR technology was now being directed towards genetic manipulation of female mosquitoes to reduce reproduction. Next slide, please. As Dr. Teddy Potter described last week, we have a role in reducing environmental injustices so evident in vector-borne diseases. As nurses, we're at the front line of the battle. Our voices are critical to communicate the health impact of climate change on vector-borne diseases. So what can we do as nurses? We can educate, we can model behavior, we can conduct surveillance, we can advocate to our policymakers, our Ministry of Health, for funding and for partnership. I want to remind you that the key goal of this course are to increase nursing knowledge, equip nurses with skills, and build an informal or informed community. And I hope I've been able to do that to you today. Last slide. Climate change will have different effects on vector-borne diseases in different countries in the world based on a variety of variables. The main driver of the biology and ecology of vectors is their sensitivity to temperature, precipitation, and humidity, the very same conditions that climate change impacts. We can have an impact on these things too. Thank you so much.
Thank you so much, Dr. Kelly. We have a number of questions that were placed in the chat during your talk. We're not going to be able to get to every single question, but we will do our best to try to address some of the really outstanding questions that our participants have added. So the first question here in the chat, there's an increase in snail infestation that has occurred locally, particularly giant African snail. What diseases are associated with this vector, or is this zoonotic transmission of diseases?
Schistosomiasis is the disease that we often see with snails. So that's a disease that we might see more in those areas. Yes.
Okay, thank you. Could you give an example of how drought can affect vector breeding and vector-borne disease?
Yeah, so it's interesting. You would think that drought would reduce it, but in fact, a lot of people have to collect water during drought seasons because there isn't any water around. So if they collect whatever rainwater and then they have it for an extended period of time, if that water is not covered well, even a small amount, as I mentioned, I have this little cup of water that has maybe half an inch of water on it, and that is enough for mosquitoes to breed. So even in droughts, we'll see an increase in vector-borne diseases.
Thank you. How can we fight against the public health misinformation that's increasing in the UK and the US? For example, in Florida, the USA took Zika seriously, but that was almost a decade ago. I imagine it will be harder to educate about public health dangers in the future.
Okay, that's a pretty challenging endeavor. Interestingly, Zika has gone down in number. So yes, you're correct. When it was coming into Florida, there was a huge outcry of the fear of Zika. That number has gone down. We don't know whether or not that's going to come back. I think as nurses, and we've said again and again, we are a trusted profession worldwide. It's not just in the United States or high-income countries, but in countries throughout Africa and Asia, we are a trusted profession. So it is incumbent upon ourselves to have the correct information and to convey the correct information to our patients. I think what we want to do more than anything else is to reduce disease and inform our patients. There's no benefit to us to lie about what we might be saying. So I think we need to maintain our trust with our patients and to give them honest answers. I think the other thing, which is very, very challenging, is to try and keep politics out of it. What I try and say is, it's just the facts. I'm just giving you information. I'm not trying to lean politically one way or the other. I'm just giving information. I think we've lost trust in some of our government organizations I wanted to mention West Nile, who Tony Fauci, who had been the head of the CDC infectious disease, got diagnosed with West Nile. And he was a man who tried very, very hard to tell the truth. And I think was very challenged by people trying to push back against it. So I think it's having the correct information, looking at evidence-based research, and conveying in a time that doesn't seem as though you're saying something political.
Very, very great advice. Another question is, when we reduce mosquito and other vector animals breeding in populations, do we risk doing other environmental damage?
We sure do. That's a big problem, right? You want to do one thing and something else occurs. So repellents are used, different kinds of sprays may be used in environments, but we can also reduce the number of bees and butterflies and other kinds of insects that are valuable for our environment. So we need to be aware of. Some people have often said that spraying widespreading across environments are not the best idea, because it does harm other insects that are important for breeding that we want in our flowers and vegetables. And so things like more topical or spraying with promoters is a better way, because what we're trying to do is reduce our risk of disease. No, we don't want mosquitoes around, but we just don't want biting. So when I was reading that one article on the CRISPR technology, I found that really interesting. If it could be specific to female mosquitoes and not impact other diseases, or other insects.
Sure. In the context of climate change, is there any way that vector-borne disease can be completely avoided in the future?
I don't think so. I think where we may want to look is, how can we treat them better? How can we identify them better? I was listening to a lecture a little while ago, and one of the things that I thought was very important is that, as I mentioned, the reason I used Rwanda, other than living there and loving it as a country, is that it's used to malaria. And so anybody who has a fever pretty much is going to get a malaria smear. Another important thing is that people that have dengue, at least 50% of them also have malaria. So if you're going to do a malaria smear on a person that you think has malaria, then you would treat them, right? Assuming that is their primary disease. But they may have dengue as well. And so one of the things that was discussed in this lecture was to expand diagnostics beyond malaria. That malaria, is, yes, a huge killer of people worldwide, but we need to look at more expansion of diagnostics. So I mentioned doing serology and typing, and we probably need to do that more so that we can identify people at risk earlier, faster, and intervene. I would also like to venture that we need to help out low-income countries with their health delivery. They don't have the infrastructure, they don't have the money, other countries do. So I would like to see more partnerships, more collaboration, so that we can intervene faster with people that are infected with vector-borne diseases.
Thank you. The Wolbachia Aedes mosquito suppression strategy has shown a 90% reduction in the Aedes aegypti mosquito population, and up to a 77% of population are less likely to get dengue in those release areas. Do you know of other examples where we're trying to combat vector-borne diseases?
I think every country has some management programs of vector-borne diseases, even at a local level. Most cities and government officials in many of the countries of the world have vector-borne programs going on. I don't know of everyone going around, but we certainly do have vector programs going on in countries and in cities throughout the world.
Thank you. And I think we have time for one more question. So we'll wrap it up with, How can nursing professionals best advise patients that may live in areas prone to mosquito-borne diseases? What advice can you give to patients in low resource settings?
Well, I would begin by saying the community health workers are the ones that are best able to answer that question, and they are excellent sources of information. I think they're also, as I mentioned earlier, excellent models of turning over mosquitoes, of sleeping underneath mosquito netting. Now, as I said, the day biters are not going to be helpful because if you're using insecticide-treated bed netting, but seeing them as modeling behavior of using the insecticide, turning over water, being aware where mosquitoes breed, things of that sort. I think they are the best source, and then we should continue to use community health workers.
Thank you so much. And thank you all for joining today from all around the world. An immense gratitude to Dr. Tracy Kelly for sharing these tremendous insights today. I hope you all please join us again next week for session 3, which will be on water and food-related illness with Dr. Martha Fuller. Goodbye, adios, au revoir, and auf Wiedersehen. See you later.